So my name is Dustin Constant, and I practice in Vero Beach, Florida with Vero Orthopedics. In this particular case, we're going to use CartiMax in order to repair an osteochondral lesion arthroscopically, showing you the arthroscopic delivery system.
So we'll create the traditional anterior medial and anterior lateral portals. Anterior medial is between the tibialis anterior tendon and the medial malleolus. And with a 30-degree scope, you want your camera aiming towards the ankle joint, no matter what position you have that patient in. You can see some of the red hemorrhagic synovitis here. Next, we'll create a lateral arthroscopy portal just lateral to the peroneus tertius and intermediate dorsocutaneous nerve. Typically, these are marked out preoperatively. By flexing the fourth toe down, you can identify the nerve and go just lateral to that. Make a stab incision. You should be able to see it under the camera here. And for us, we want to be able to create a lesion somewhere in this area. So we're going to take a shaver and shave off some of the articular cartilage to prep it for repair. All right, so let's go ahead and create our injury to our cartilage here. So we're going to shave down some of this cartilage, create a large injury. So this would be a great lesion to test the CartiMax on. We're going to create sort of an uncontained lesion here so we can test the pliability of the tissue and to see if it holds while we're putting it through range of motion. So once the lesion's identified, you're going to go in and clean up the lesion with articular until the articular cartilage is smooth around the area. So we're going to try to clean up some of this tissue here. We've got the suction on to pull some of the tissue in. All right, so there's our lesion. So the first thing I like to do once I identify the lesion and clean it up is I like to create edges that are vertical around the cartilage. The reason I like to do that is it allows the CartiMax to hold in position. So I'm going to go in here. I'm going to have my assistant flex the ankle down a little bit more if you can. And I'm going to try to create nice vertical edges here along the edge of the cartilage. So we're going to go remove some of these chunks as they come out of the cartilage. We're going to go back in and shave this one more time. Now this is a good defect. You can see that actually you can pierce through this subchondral bone and into the cancellous bone here. This can be performed. Currently we're using a 4.0 scope. I like to use sometimes a small joint scope, which is used in hand and wrist. Can range anywhere from a 2.5 to a 3.0. It's all surgical preference. The field of view is larger on this 4.0 scope. However, the maneuverability of the smaller scope is nice for getting lesions that are more posterior, and you can see back into the posterior aspect of the joint. Now, meanwhile, all this is going on. Your CartiMax is thawing on the back table. It needs anywhere from 15 to 20 minutes to kind of thaw out. Place it in some warm water. All right, next on the back table, after your CartiMax is thawed, it will be in a pink solution, cryopreserved solution, and we want to drain that first. So we'll put the strainer on, and we'll begin draining that slowly. And then we'll begin a rinsing process. Next, we'll add normal saline back through the strainer. I'm trying to get all these little pieces and chunks off here so that we can re-rinse this area. Again, pass it through the strainer slowly and rinse off the cartilage. I'll usually do this 2 or 3 times until I feel like it's nice and clean. You also notice that the cryopreserved solution will be gone at one point. I know that I'm done when I fill this solution and it is clear again and all the cryopreserved solution is off of it. Next, we'll remove the cap and we'll gently kind of save the remaining portion of the cartilage and pass it back into the open container. Now, if you're doing this for a big open procedure, you would want this much drier because you don't want it as flowable. You would want to keep the material very putty-like consistency. You want to have some flowability of the putty as we're going to pass it through the cannulas. We're doing this arthroscopically. Again, there's a little bit of solution left there, so I'm going to pour that out and kind of preserve what's left. And then we'll begin the mixing process with the matrix allograft. So this comes in a vial ready to go. We mix the cartilage matrix allograft in with the femoral cartilage here, and we'll begin mixing. And this is usually performed on the back table by my surgical tech or my assistant that's assisting me in surgery that day, first assist or my PA. And this will be mixed on the back table. Now, prior to putting this into the cannula, though, I want to check the consistency, and I want to know how flowable it is for myself in order to use this. This consistency looks pretty good. I'm going to keep mixing here. You want to kind of get as much as you can. Now, with this one container, we can do 5 square centimeters of surface area. And that's a pretty large lesion in the ankle. That's typically anything over 1 centimeter where we're using some sort of augmentation for. Now we're going to start packing this into the cannula. So first I'm going to take the spatula and try to carry as much of this into the container as I can. Now remember, this is a good option for cases when you don't know that there's an articular cartilage injury in there. You get surprised when you go in arthroscopically, because this can be kept on the shelf, cryopreserved for 12 to 24 months. 24 months. So that gives you a good option in case you weren't expecting that lesion to occur. Yeah, we're just pulling the plunger back so that we can pack the matrix into the cannula. And I like to just spend a little time here to make sure I get the excess off, because some of it will get caught within the threads here. Sometimes I'll pack this down, and if I know I have a larger lesion that I want to have as much cartilage available as possible, I'll even go back in with the freer and just kind of follow the threads around and pack it back down in the bottom of this. This will kind of free up the matrix so it's not hung up here in the threads of the cannula. Once you're happy with that, you'll screw the threads of the cannula on, and you'll start seeing the matrix flow through the cannula. Once tight, then we're prepped to get the joint ready and use the matrix. Typically, we'll use cotton tip applicators in order to dry out the lesion. I personally prefer foam tip applicators, because they sometimes with the cotton tip applicators they'll shred or fray while you're inside the joint here. All right, so next we want to move forward with drying out the joint once we put the arthroscopy camera back into the joint. I like to use the microfraser tip here. I will typically have the suction turned off so that I can get into the joint easily, because the suction will start pulling some of this tissue in with it. And once I'm happy that I'm in the joint and where I want to be, then I'll have the suction turned back on by my circulating nurse, and I'll get in here and just kind of dry this area out really good. Now I'll take some foam tip applicators and we'll start drying out the joint here. Now it's going to take us a little while to dry out this joint. Typically with your patient, you can dry it out a little quicker. With a cadaveric patient, it tends to go a little slower because of the thawing process of the cadaver. So it tends to be a slightly bit more damp in this area. So we have to take our time to get it dried out here. And you can see the walls of the cartilage. I like to make sure that they're somewhat vertical there. That way it contains the cartilage matrix as we're flowing it in. Now, typically, if you're using a small joint shaver and a small joint camera, the portal that you're utilizing to pass the matrix, you have to widen slightly. We are using a larger joint camera here, so 4.0, so that's not necessary. All right. All right, so we can see the cannula here, and we like to use more, kind of overflow the area. It's okay to go a little bit more with the cartilage than it is to not have enough in there. We can always clean it out and smooth it up later. So I'm going to start flowing that in right here. Now I'll get the first bit in and I'll pack with the applicator. we'll go back in and flow a little bit more. And during this process, I'm actually trying to create a seal here over the lesion if it's small enough, and I'm trying to really force this matrix down into that area. You'll see some of it coming out here on the side. Nothing to worry about. We'll clean that up later. This matrix, CartiMax with the cartilage matrix putty is a little thicker than most of the other things on the market. Therefore, it tends to hold position a lot better. All right, I would like freer next. Now you can use a joint spatula, or a freer can work for this particular part of the procedure, and you just want to use the back of the freer here, kind of go in and pack this cartilage down in here. And again, don't worry about the excess. We're worried about filling the lesion and making sure it's to the surface area of the injury. You don't have to use fibrin glue if you don't want, depending on whether the lesion is contained or uncontained. I still sometimes will go back and add fibrin glue myself just because it makes me feel better, or if I have a patient that is I know is going to be non-compliant, and I want to try to get them to seal up a little bit better because I know they're going to walk on it even though I tell them not to. And we all have those patients. So what I'd like to do here is I'm going to put it through range of motion. So you can see the transition zones from the regular cartilage to the defect, and then back to regular cartilage closer to the bottom of the camera there. We can also try to put this through range of motion, and you can see how it's not moving at all. Yeah, so postoperatively, we typically like to keep these patients non-weight bearing for about 2 weeks. Then I'll transition them into a cam boot. They'll be in the cam boot for 4 to 6 weeks, depending on the size of the lesion. Now, if this is uncontained lesion and I'm doing a combination of an Oates and a CartiMax or something like that, the non-weight bearing period might be a little bit more extensive.